thanks again for the lovely introduction and the conference organizers for the opportunity to discuss this topic. Anna has given you probably more than a fair view of what is coming. I'm an NIHR clinician scientist, so just to acknowledge my funder, I don't have any conflicts of interest. This data that I'm going to present uses the ICNARC database linked to the hospital episode statistic data. So some of the things that Anna used for the GIRFT is essentially what we have used as well. And the focus is about sepsis survivors, what happens to them. And that's the kind of the paper. It's an open access paper, and if any of you can't download it, please email me, or Tara knows my email, and I'll gladly send you the paper, and that's the co-authors. So the bright idea came about probably 2016 when I was applying for my fellowship. I thought, well, what happens to patients who recover from sepsis? We don't seem to do any follow-up. They seem to have a lot of comorbidities. And I did some focus groups, and one of the things that came up in the focus groups is that actually a lot of relatives who have recovered from so-called sepsis and infection often are never able to go back to their normal day-to-day activity. They are physically impaired, they're mentally not back to their baseline, and their comorbid conditions like asthma or COPD is not optimally managed, and they accrue more morbidity like cardiac failure that is new, or some other morbidity or frailty that prevents them from getting back to normal. And I think that's kind of where the whole idea comes from, which is, could we actually identify things that we normally collect instead of going to find some serum rhubarb or something else, which would be lovely, but to something that we all normally use to figure out, can we identify a high-risk population? So that's a basic idea. And the reason why I've chosen the outcome of unplanned rehospitalization or death is because it is common. It's very common, as Anna highlighted in the previous talk. It's very common than we think. And actually, because we know we do have information on who had a particular illness and who are being discharged from hospital, we could actually be sitting on something that we are completely ignoring. So that's a basic premise of this whole scoring system that I'm going to talk to you about. So before you develop a scoring system, as we all do, I kind of did a systematic review of the literature to try and understand what are the risk factors for long-term mortality and what are the risk factors for rehospitalization in sepsis survivors. And those two are, again, open access papers. If you want, please ask me and I'll send you that. And what we found is that almost nearly 50 or 60 studies within these two papers highlight consistently things that we actually collect. If you're older, if you got comorbid conditions, if you had a bad bout of sepsis, you are likely to come back to hospital. And partly, it is just the fact that purely the NHS as a state-funded healthcare system probably didn't have the resource to follow up all of these patients. But could we actually predict some of these likely risk factors that contribute to rehospitalization? Can we do something about it? And it's not a rare event. 1 in 6 sepsis survivors don't make it out of 365 days following leaving hospital. They die within the first year. And nearly 40% of them have at least one rehospitalization. And we started to look at what contributes to this and how we can prevent it. So the basic study design is take the ICNARC database over a 5-year window, follow up these patients, and then look for the outcome events of rehospitalization or death. We had a 5-year follow-up in total, but the primary outcome was 365 days, and link the ICNARC database to the hospital episode statistics. So there is no new data collection apart from using what is out there and actually using it better. As I kind of said, basic data is the ICNARC database. We had roughly 100,000 sepsis survivors over a 5-year window. Critical care units in England, we didn't have the data from Wales and Scotland, but the Wales group have replicated what we have shown. And we do the kind of bit of statistical magic of commonly available variables. It's a logistic regression model with 20 predictors. And we divide the database into a derivation and a validation cohort, which is methodologically what you would need to do. And what you see, this is the first kind of major kind of result, which is if you look at the figure on the left, the figure on the left is about mortality, and the figure on the right is about rehospitalization. What you see here is the increase in rehospitalization events with time, and probably by 90 days or so is the 0 to 90 days the peak rehospitalization events, and then it gradually plateaus off towards the end of the year. And there is infection-related rehospitalization happening even in sepsis survivors. And I think the most common reason why sepsis survivor comes back to hospital, not critical care, but to hospital, is infection. Either an uncontrolled new infection or a infection that is resurfaced following the first recovery from first infection. And we also looked at what are the common scenarios. When we looked at the data, what we see here is that sepsis survivors, like most of the critical illness survivors, gets discharged to home, not to nursing home or anywhere else. They just go back home or their usual facility, and they come back into hospital. And people kind of highlight this as happening. They survive sepsis and they go and die without us knowing. That is not true at all. 98% of scenarios are you go to your usual care facility, home, nursing home, or whatever your usual care was before you came into hospital, and you're coming back in from there. So there are so many opportunities to prevent this event from happening. So I don't want to go into the nitty-gritties of logistic regression, but what we end up with is a very, very simple score that can be adopted across the NHS fairly easily. What we have is age, previous hospitalization, more the number of previous hospitalization in the year preceding admission, greater the risk of rehospitalization or death in the first year. Older you are, greater the risk of rehospitalization. If you have deprived without bow tie that Anna highlighted, you are going to be rehospitalized more frequently. The risk is pretty spectacular. If you had any form of dependence prior to hospitalization, you're going to be rehospitalized. If you have one or more comorbidities, it doesn't matter what comorbidity it is, you will come back to hospital in the first year following discharge if you're a sepsis survivor. Emergency admissions often have a greater risk of rehospitalization, but actually quite a lot of the elective surgical patients come back in if they had an in-hospital episode of sepsis during their elective surgical episode. If you have low hemoglobin at admission, it's not discharge hemoglobin. When you came into hospital, if your hemoglobin was low, you're likely to have a greater risk of coming back into hospital in the subsequent year. And the site of infection is the other predictor, and compared to all the other predictors, the site of infection is not that much of a risk predictor, but it is an important contributor to rehospitalization events. So if you kind of think about what we all do, none of this information needs any additional work. It is all collected as part of every single NHS episode. It is not new, it's not revolutionary, but we don't use it. And quite a lot of kind of background work went in. Just to highlight, the figure A is how common is the score distributed across the population. And you can see that as you look at the change in color, the top right-hand corner, some score of somewhere between 5 or above is associated with a risk that we think from focus groups patients consider as important. And that's a kind of the performance of the score. And often the argument you get here from folk is that actually the AUC, area under the curve, is only 0.7. Actually, it's important to understand that we are not trying to perfectly predict what is likely to happen, which is rehospitalization or death. What we are trying to highlight is there is a gradient of risk within those who recover and leave hospital. And given the limited resource we have as the NHS, you can prioritize who to actually follow up. And if there was infinite resource, we would follow up everybody. But because we don't have infinite resource, we prioritize. And that's what this score is for. It's not to kind of say who should get follow-up. It's just to say how many patients can you follow up in your hospital, and you do your best. And this is where the so what and who cares comes in. And at this point in time, I can definitely say none of us assess a sepsis survivor's risk of rehospitalization or death in the first year in a rigorous fashion. None of us make an effort to follow up. We have arbitrary rules for follow-up. if you're on a ventilator for 3 days, you get a follow-up. But if you have sepsis and you stayed in ICU for a period of 9 or 10 days on a non-invasive face mask, you don't get a follow-up. I mean, it's as arbitrary as that. So there is plenty of scope for improvement. And actually, when we, as part of a clinical trial of vaccinating sepsis survivors that I'm doing, we did focus groups. And actually, every single sepsis survivor or their relative was happy to have any form of follow-up care, even if it is just optimizing their comorbid condition. And they're not getting it. And half of those GP attendances in the first 3 months is because hospital doctors have stopped their comorbid condition medications, because when they were in ICU, you change the drugs and you never restart some of those drugs. And you add some of those drugs and you go home with it when they shouldn't. So it's just a combination of simple things that we need to do to make this better. And it's just if you are into health economics and health services modeling, this is the sort of thing that people will talk about, which is what is the threshold probability and what's the net benefit of doing all of this. And in a very simple way, threshold probability is I, as a sepsis survivor, might value an intervention that helps me feel better. And that may not make the healthcare system lead, that may not make the healthcare system save money, but it will make me feel better, and perhaps I wouldn't come into hospital or contact my GP for doing something. And if we use that sort of principle, and this graph essentially summarizes that. Let's say that we have some money, and if the score is around 7 or more, we need to follow up roughly half of those sepsis survivors. And if you have less money, you follow up an even higher risk group. But this score gives you an opportunity to kind of say, this is the population that we want to follow up, should we have the funding? And I think it's important, one final point about this data, this is not data from the US, this is England, this is NHS, this is routinely collected data, this is data that you provide to ICNAC and to hospital episode statistic that we all do. And that is the data that is used to derive this score. So I'm not actually cooking up anything that you don't know. This is out there. It's just that we don't act or use it. And to kind of briefly summarize, it's a very simple score. It uses information that often provided by clinical history, like did you get hospitalized in the previous year? Quite a lot of the information from our database. How old are you? What comorbidity do you have? Did you have a surgery or did you have an elective admission? What was your hemoglobin at start? And what was your site of infection? And depending upon the resource we have, you can follow up these patients. And this score is free online tool. Anybody can use it. And it's valid for using in England because every single data point is based on the English data set. And if you can't access this tool, just send me. There is no patent. It is NIHR funded research. You can use it freely. Yeah. And I think that's where I'll stop, and I'll take any questions or comments.
Hi, good afternoon. Thank you. That was really interesting. My name is Christine Duffy. I work in critical care and also in primary care in GP practice. And I find the interface between critical care and primary care quite interesting. So I'm interested in finding out how we can link this back to GPs, because I often see discharge summaries when patients have been in hospital, and often there is, in terms of GP follow-up, it says no instructions. Obviously, if it's somebody who has had input from orthopedics, they will want to see them because they want to check on their bones. If they've had cardiology involvement, then they will want to see them. But from a general health, for example, sepsis and that sort of thing, similar to what you've said, what recommendations would you give for us in primary care if we are seeing patients that have come back post-critical care admission?
So I think great question. The first thing I'd say is the critical care and hospital discharge summaries don't collect or explicitly state sepsis in quite a lot of them. So you have a primary problem of hospitalists not doing the kind of thing that they're supposed to do with discharge summaries. I think step one is that. Before the pandemic hit, I was in email contact with Anna. We were trying to figure out a way of kind of implementing this. And then the pandemic hit. And I'm sure in 10 months' time, somebody will reinvent the wheel and create a scoring system for COVID survivors too. And it is possible that to adopt something like this, it is funding. It's down to funding and some sort of health improvement project that we all need to get involved in. Other than that, I don't have any good answers to your question, but it is an important question, and I've thought so much about it. But at the moment, we don't have anything. We were going to put in a grant, but anything other than COVID, you don't get a penny.
My name's Julia. I'm an outreach nurse from Taunton, but my trust has just invested in a rehab service. So it's very fledgling, but they are anybody that's had a prolonged stay in ITU, and they are following up with that. And we have a nurse who works in the service. We have a consultant, and we are just recruiting to a clinical psychologist as well. So hopefully, once we can get through this and out the other side, patients will get better treatment post their ITU discharge.
Oh, that's great. Thanks for it.
The average GP sees very few patients who've had a long critical care stay, or even a short critical care stay. So they're really probably not tuned in to this sort of problem, and it would be so useful if we could include this sort of information, because if we can't fund follow-up, the GPs are going to have to pick it up, but it's a different world to them, and I think it's fascinating that you've got a job that kind of strides across both, but it's an area where we could do better at informing people, isn't it?
Yeah, absolutely. I completely agree.